More than 8,000 patients have contracted Ebola, with new cases coming in the hundreds every day. And it doesn't stop there, because infectious diseases know no borders. Joining us now for more on what we know about the disease and our preparedness to deal with it, in Geneva, Switzerland, via Skype, Dr. Joanne Liu, International President of Médecins Sans Frontières. In Windsor, Ontario, via Skype, Dr. Tim Jagatic, a physician for MSF, recently back from the front lines in Guinea. And with us here in studio, Dr. Brian Schwartz, Chief of Emergency Preparedness at Public Health Ontario, Dr. Vanessa Allen, Chief Microbiologist of Public Health Ontario, and Helen Branswell, medical reporter for the Canadian Press. And we're happy to have so much expertise on this issue gathered around this literal and metaphorical table, as it were. Get comfortable, everybody, because I want to just get our viewers up to scratch on the latest. We're going to bring up a few graphics here just to tell everybody the latest. Past Ebola infections from 1976 to just prior to this latest outbreak are located mainly in Central Africa. The present Ebola outbreak is, of course, in Guinea, Sierra Leone, and Liberia, and it has since been transported to Senegal, Nigeria, where it is now thought to be contained there. That's the hope. Let's continue. In Guinea, Sierra Leone, and Liberia, more than 8,000 cases of Ebola identified, more than 4,000 deaths currently certified. And one more graphic, there are now Ebola cases beyond Africa, as you've no doubt heard, with these cities dealing with isolated cases, largely imported from West Africa, except in the cases of Dallas and Madrid, 3 nurses so far having been infected by patients that they were treating. Let's get into this. Dr. Tim, start us off first. How did this outbreak grow so big so fast?
Well, the big thing that happened was what we were dealing with was an outbreak which the first time ever in the history of Ebola, we've had an outbreak in a major urban area. And with an outbreak in a major urban area with a lot of mobility in and out, we had a particularly new situation. Prior outbreaks were always in small rural areas where very low mobility, very few people, but now we had highly densely areas being infected with and very low levels of hygiene. So you combine low levels of hygiene, densely populated areas with high mobility, you will have a serious situation. And unfortunately, we're dealing with the worst case scenario.
Helen, can you tell us how previous outbreaks, decades ago, of Ebola compare to the one we're in the middle of right now?
Well, the first outbreak happened actually the first 2 outbreaks happened almost simultaneously in 1976, one in what is now the Democratic Republic of Congo and the other in South Sudan. And over the years since then, there have been somewhere between 24 and 36 outbreaks, mostly in Central Africa, as you noted, and typically they were in remote places. Sometimes it took a long time for them to come to the attention of authorities in the wider world, the WHO. But when that would happen, teams would be sent in, mobile labs from, for instance, the Canadian National Laboratory in Winnipeg. MSF would set up treatment facilities, and using the tools that have been traditionally used, identifying patients, isolating, watching their contacts to make sure that they aren't going to get sick, burying the bodies safely when deaths occur. Those tools manage to break the chains of infection. And that, in fact, has just probably happened in Democratic Republic of Congo, which has been also having an outbreak now that is distinct from the West African one.
Dr. Liu, let me get you to amplify on that, if you would. Why is it different this time?
Well, I think that in addition to what my colleagues have said before, I think is the fact that people were not exposed initially, so didn't know the disease. The fact that I think that we had a lull as well in the month of May, where in Gekedu and Guinea the cases were quite decreased, and we didn't have cases for a few weeks. And then for some reason we thought that we were ahead of the game, but basically we were not. And after that it outburst again. And then because Gekedu, where was the initial epicenter, is at the confluence of 3 countries. It spread to 3 other countries. And the mix of hitting a country that doesn't have medical healthcare infrastructure that are strong but rather weak was as well, I guess, amplified the situation. That's one thing. The other thing is I think that we were very, very slow to answer. We rang the alarm as an organization, but I think it took several weeks, if not months, for other organizations and states to somehow wake up to the magnitude of the epidemic.
Tim, I have to ask you, first of all, when were you in Guinea treating people there?
I showed up at the end of March, and I was there through part of April.
How many cases of Ebola do you think you saw?
In that little chunk of time, I saw just about 30 to 40 cases. When I was speaking with the epidemiologist at the time, after the first week and a half, when she sat down, after she did her contact tracing, after she had all of the hot zones within the city set up, and when she looked into the mobilization of the people, she said that we should be really expecting one of the worst outbreaks.
And let me ask the obvious follow-up. Why weren't you scared to go there?
Well, I really do have a lot of faith and confidence in the MSF protocol that we have for our personal protective equipment. We are very stringent. We have very well-trained people, both on the international level and on the national level, who make sure that we do everything we possibly can to prevent infection of our health staff.
And I actually got an email just before we started taping this program from another producer of another program who said, ask him about the protocols for removing equipment, because she had heard that there are people who take one glove off with a covered hand, of course, but then use the bare hand to take the second glove off. Did you see any of that, or any other protocols perhaps not being followed as carefully as possible?
Well, our protocol involves meticulous hand washing in between every single act that you do. Every time you come in contact with the outer layer of your personal protective equipment, you have to consider your hands contaminated. That's what we do. And so we always wash our hands in between every single act. And then when we finally get down to our final pair of gloves, where we are now using our bare hands to remove them, we slip one thumb underneath the glove, we carefully remove it into the bin, and then again we wash our hands with the chlorinated water. And then we don't make contact with ourselves. We don't touch our face, we don't touch our body, nothing like that, for another 5 to 10 minutes afterwards.
Okay, understood. Vanessa and Brian, our friends from Public Health, before I get you in, I want to read something here, and then we'll get you to follow up and comment and share what you know about this. This is from Vanity Fair magazine from earlier this month. The way Ebola kills would seem impossible to mistake. What the casual observer knows of Ebola are its most spectacular cases or the cinematic depictions of them. Prodigious bleeding from eyes, ears, nose, anus, and nipples. Symptoms like these presenting all at once would be impossible to miss or misinterpret. But not every Ebola case ends with such a biblical scourge, and many of Ebola's symptoms are identical to those brought on by other diseases. Until its final stages, Ebola can easily be mistaken for cholera. It can also look a lot like malaria, another long-tenured killer in Guinea. What no one has ever died of anywhere close to Guinea is Ebola. The last big Ebola outbreaks in Uganda and the Democratic Republic of the Congo in 2012 were more than 2,000 miles away. They might as well have been in another world. If you'd told any of the investigators, as they considered the crisis developing in Meliandou, that they were looking at Ebola, they either would not have believed you or just as likely would have asked you what Ebola was. Okay, this is very unusual because, of course, the world is obsessed with this right now. They finally found something worse than Islamic State to be concerned about. And, this is not what we think. What I've just read is not what we think. So let's go through this. How do you get it?
Absolutely. So the transmission is really by contact, and it's contact particularly with highly infected fluids like blood, vomit, diarrhea. Those are the most highly infectious. There is some hypothetical possibility that it's by droplet as well in a coughing patient or a highly aerosolized procedure. It is not transmitted by airborne transmission, and it's really important to note that. And so really it's all of the personal protective equipment that's been designed is really to protect the healthcare worker and the contacts in the context of droplet and contact primarily. And so in that sense, I think it's really, really important to note that just being in the vicinity of a patient is not a high-risk procedure. It's really touching the patient, embalming the patient, as certainly has occurred in the context
Well,
of
that's
West
the thing
Africa.
we've got to get to the bottom of here, because some diseases obviously are hard to get and some are easy to get.
Right.
Which one is this?
This is more difficult to get, but the severity of disease is so high that it warrants the utmost attention in terms of prevention.
Okay, Brian Schwartz, let's talk about international travel. One of the things that we're hearing about, for example, might be temperature screening of people at airports before they come here. Would that be effective?
Probably not. The science says it isn't. Certainly our experience in SARS showed that nobody was identified with temperature screening.
You need to take 30 seconds to remind everybody about what severe acute respiratory syndrome was when Ontario faced it 11 years ago.
Thank you, Steve. Severe acute respiratory syndrome came to Canada, specifically to Toronto, in 2003 in February. We didn't realize it was there until the second patient presented to the healthcare system, and we soon found out this was the same disease that was ravaging Southeast China and other parts of the Far East. SARS took 44 lives in Ontario, sickened about 400 people. Obviously, the mortality rate is much lower in SARS, but it was easier to catch, and it was a disease that was respiratory spread.
How satisfied are you that the world is treating Ebola cases in a way that will ensure we don't have the same outcome we did 11 years ago with SARS?
Well, see, there's absolutely no guarantees, as we found out in the last few days. But SARS and other other world events and the reaction by countries through the WHO and the existence of agencies in Canada like the Public Health Agency of Canada and Public Health Ontario, which owe their existence to the aftermath of SARS, are set up to be able to detect and identify these agents when they come to Canada.
The federal health minister, Helen, the other day made an announcement about vaccines and treatments. Can you bring us up to speed on what she had to say?
She declared the fact that a Canadian-made vaccine is the first clinical trial for that vaccine is starting this week in the United States, Walter Reed Hospital in Bethesda, Maryland. There's a lot of excitement about that vaccine. There's a lot of hope that it could be really useful, and there is also a lot of fear that this outbreak in West Africa will not be contained without vaccines. So there's a real push on to try to accelerate all the work that can be done on testing and then producing this and another vaccine that was designed at the National Institutes of Health in
Okay,
Bethesda.
but if I get vaccines, you got to take the needle before the thing hits you, right? Once you've got it, is it too late?
The Canadian vaccine was designed to be both useful as a pre-exposure vaccine, so something you could get before you got sick, and a post-exposure vaccine if you took it quite quickly after exposure. That has proven to be true in animal studies, primates, but we still have to see how it works in humans.
And it would have to be pretty quick, because the incubation period could be fairly short, I would think.
Incubation period is what,
For
5
it's
5 days to 2 weeks, I think.
as short as 2 and
21
up to 21.
Up to 21 days.
Yeah.
So you'd have to move quickly
So
on this.
post-exposure, I think, would have to be pretty quick, I guess.
We'll see, I guess.
Yeah. But
They
even
gave
if
it to a German researcher in 2009 who had a needle stick injury in a lab accident in Hamburg, I think it was, and she received it several days after. In that case, it was never clear whether or not she was infected. She survived, but it's not clear if it was because of the vaccine or because she had not infected herself.
Well, we don't have the vaccine yet, Dr. Schwartz, so what are, I was going to say we, but what are you healthcare people using?
No, it's all of us.
All right, so what are we doing to treat people who've got Ebola right now?
Well, to treat people with Ebola, well, there are no approved treatments for Ebola. There are a couple of experimental treatments that have been used. A Canadian company has developed a monoclonal antibody, which essentially is a an antibody targeted towards that specific virus, in this case Ebola, and it was associated with the recovery, at least of 1 or 2 patients. We don't know whether that would have happened anyway or whether it's the result of the treatment. The problem is now they've run out of the stuff, and they're trying to manufacture more. Other treatments include the convalescent plasma of people who have recovered from Ebola, so that they've already developed their own antibodies, and their blood products can be transfused into people who are suffering from it to help them recover and boost their own immune system. The problem is, again, this stuff's in short supply.
Let me pick up on the first thing you said there with Dr. Liu, and that is, how is it possible? This is not a new disease. You have experience with this disease going back at least 40 years, which is the lifetime of certainly the people on the program here today. How is it that there is no internationally agreed upon protocol for fighting this thing?
Well, I think it's I would like to go back to the treatment, because I think that in terms of getting an overall agreement, unless we think it's a global threat and then we are, I would say, feeling close and knocking at our doors, I don't think that people are going to pay attention. And actually, what happened with this Ebola epidemic, that we like it or not, it's until some of our colleagues from Samaritan first got infected that all of a sudden the world paid attention. So it's unfortunate. I think one of the things that we have to say is this has been existing since 1976, had 18 epidemics in its history, and then we haven't, I would say, evolved that much in research and development. And the reason why is, I guess, somehow it was really never considered as a threat. Most of the epidemic died out on themselves, but there was always some research done because of this, I would say, growing concern about biohazard and bioterrorism. And so this is why we know that some DOD have been doing some research, and this is why there is still some I would say, different type of treatment available around the world right now that's going to be tested and started to be tested over the next few weeks.
Helen, a follow-up?
Yeah, I've been writing about the search for Ebola and Marburg, which is a related virus, therapeutics for years. And a lot of the work has been done at Winnipeg, also a lot in the United States, most of it funded by the US government.
In Winnipeg because?
Because there were some of the best scientists in the world on Ebola at the Winnipeg lab. And you know, government defense funding got the project so far, but if you're going to produce something in mass quantities or even test it in humans and therefore have to take on the cost of doing that, it requires sort of big pharma type pockets, and there has been no interest on the part of big pharma in these products up until now because there's no market for them. These outbreaks happen sporadically. They happen in parts of the world where people are poor and will not be able to pay for the vaccine.
Is big pharma interested now?
You know, GSK, which is
GlaxoSmithKline.
Yes, exactly. They have the license for the American Ebola vaccine. So yes, I guess that's true. And I think that it's also true that the economics of this may be changing. Unfortunately, it seems to take the notion, as Dr. Liu was saying, it seems to take the notion that it's a threat to us to get that piece of the puzzle in place, but it may be changing.
Vanessa, should it disturb us that there are no internationally agreed upon protocols for fighting Ebola? Because it sounds like we ought to be concerned about the fact that there is no internationally agreed upon way to treat this thing.
So in terms of treatment, there was a couple of other things that I wanted to add. I think one of the aspects that's come to light is really the ability to have a robust medical system. And so in the Marburg outbreak of 1967, where it was imported to former Yugoslavia and Germany, the mortality rate of Marburg dropped down precipitously. So it was still very high at 20 to 25%, but with hydration alone, it looked like the ability to treat patients successfully had increased dramatically.
Hydration alone meaning?
So IV fluids.
Okay.
And in fact, the individuals who were repatriated to Emory, that was one of the comments, was really the dehydration. And with that, there was some deficiencies in potassium and other items associated with this profound diarrhea and vomiting. And so I think what's troubling in terms of this is not just the hugely pathogenic nature of this virus, but also in the context of this very poor infrastructure. And so it's the perfect storm. So I think the levels of not the levels of response, but the nature of response are also different in these different circumstances. Like the ability just to have basic access to hydration, and so many different organizations have mobilized. And Joanne on the line is an exemplar. Joanne and Tim are exemplars of that. But really to think about what are the needs in those particular contexts. So treatment, I think, has various different stages. I think the fact that people are mobilizing to treatments of vaccines, serum products, these various drugs is promising. It will probably, even with the best of efforts, be quite slow in the context of what's going on.
Well, let me follow up on that. Joanne Liu, let me go to you on this one. You know, we sit here in the middle of a city with a pretty sophisticated and well-developed healthcare system, but I can imagine it's probably not up to the task of 4,000 Ebola cases, you know, landing on its doorstep tomorrow. So one wonders, given that this is happening in Africa, which may not have healthcare systems as developed or advanced as ours, has this completely swamped their healthcare systems in those countries?
Oh, I think that even swamp is not a strong enough word, I would say. We know that since the beginning of the epidemic, there's around 400 medical staff who got infected. 50% of them have died. And we know that those figures are underestimated. And that doesn't take into, I would say, account what we call the health promoters, who were really at the front line trying to, I would say, increase awareness in the community. And in some villages, we know that more than 90% of them have died so far. So we know right now that we have a weakened healthcare structure that, just for example, in Monrovia, there's 5 big hospitals, and all of them are more or less closed, excepting some few obstetrical emergencies. And then right now we're facing what I call the emergency within the emergency, is you're more likely to almost die from a malaria or liquid diarrhea by not having access to basic health care, or Ebola right now in West Africa. And that's the really, I would say, the complexified picture that we have right now. I just wanted to come back to the vaccine, because I really do think that, although I agree with Ellen Brenswell, is the fact that when you look at how the outbreak is going on right now, and the fact that this seems to give no signs of abatement, that really the game changer will be a vaccine. That's going to be the only way to somehow break at, I would say, great scale, big scale, the chain of transmission. And this is why we need to put enormous pressure in terms of research and collaborative research, and getting a vaccine accessible and affordable in big production as soon as possible.
Well, in which case, let's gauge, I'd like to get some sense, Helen, I'll start with you on this, the international, if I can put it this way, the international community's reaction to dealing with all of this. How would you characterize it?
Staggeringly slow. You know, in some ways, I kind of understand it. This has been just an astronomically bad year. When you think about all of the things that have happened, the shooting down of the plane in Ukraine and Russia, Syria, ISIS. I mean, there are so many health problems that have been going on. And then on the health front, you know, in February and early March, there was H7N9 bird flu in China. And after that, people started to become aware that there was this Ebola outbreak. And then all of a sudden, MERS, Middle East Respiratory Syndrome, exploded in Saudi Arabia. And, you know, the people who take care of this at the WHO, they're all pretty much the same people. So, you know, they're running this way one day, running that way the next day. And it's, it's just hard to keep track of all of this stuff. So in some ways, it is understandable. That said, I have a lot of sympathy for Dr. Liu. She started calling very early and telling people this is not a typical Ebola outbreak. This one is going to be much bigger. Said that MSF could not manage it on its own as it has typically.
Let me ask her, when you put those calls out there, what was the response that you got back, Dr. Liu?
Well, in spring when we started to discuss that, we of course started to do it in a bilateral way, and we were regularly just said, no, you are crying wolf. Then we said it publicly in spring, and again we were, especially from WHO back then, told that we were crying wolf, and then things were not as bad as this. And even this summer when I met again with Dr. Chan, and I discussed with her, and I just said, this is really out of control and something needs to happen. And myself, in my capacity of international president of Médecins Sans Frontières, I can call for a public health emergency, but I don't have neither the authority nor the legitimacy. And so she looked at me and she said, Dr. Liu, I don't think, I'm not pessimistic. And I just said, it's not being pessimistic, Dr. Chan, it's just being realistic. And so we pushed hard, and then finally a week after, she reconvened, and then she called the public health emergency on August 8th.
And have you talked to her since then? This is Margaret Chan from the WHO. Have you talked to her since then?
Yeah, we talked to, but well, we had to we bumped into each other at the UN briefing in September 2nd, and then as well in September 25th at the UN General Assembly.
And did you say to her, damn it, why didn't you listen to me?
I don't think I worded it this way, but I think that she knows what I think. On the other hand, my take on this today is with so few little actors, and it's so big that I think that we have to not look back but look forward. And then, as far as I'm concerned, I think I've told what I have to say to the WHO.
Brian Schwartz, I'd like to get your view on this angle of the story, which is that when Haiti had an earthquake, the world responded. When there is a tsunami in the Far East, the world responds. They put telethons on CNN, for goodness sakes. We're not seeing that this time. Why not?
Well, there's a big bang. There's a plane that crashes into a building, there's a tsunami, there's an earthquake. And it's something, there's a couple of things. We know about it when it happens. By and large, it's not an ongoing threat, although it certainly is. For example, in Haiti, they had a huge outbreak of cholera 6 months later. But people don't feel threatened by that, and they want to help, and they see it's tangible. Outbreaks don't work like that. Outbreaks sneak up on us. They're invisible. And they're frightening, so that there's an ongoing threat, so that people, even if they're well-meaning, and certainly present company on Skype excluded. I mean, Joanne and Tim are extraordinary individuals, and their organizations are extraordinary, but they're in the minority, and people don't have the tendency to step up. I think we've hopefully had a big bang moment with this tsunami of an outbreak.
What would be the big bang moment?
I think I don't know, Helen?
I would say Kent Brantley and Nancy Ritball becoming infected in Sierra Leone, or Liberia, was it? Mm-hmm. Liberia. The two Americans.
Healthcare workers,
yes,
who got it themselves.
And that's appalling.
Here.
That's really appalling. It shouldn't have taken expat workers to get infected for this to become something that the world was paying attention to. That
Maybe
outbreak,
Dallas as well? The nurse in Dallas?
Well,
might have helped?
Every single time something like this happens, it raises the attention. But I think when the world really started to pay attention was at the end of July, when it became apparent that two Americans were being infected and were being repatriated to Emory University Hospital in Atlanta for treatment. That really got attention.
Tim, why do you think the world's been so slow to respond to this, unlike other disasters?
I honestly, I simply don't know. All I can say is it's extremely frustrating. I wish I knew. I wish I could understand why people don't feel the need to participate in this thing, because everything that we're seeing in terms of our intervention has been extremely hopeful and optimistic. When we're providing healthcare, and when we're intervening, we're seeing mortality rates decrease significantly. But now when our treatment centers are being overrun, we don't have the option to actually do the work that we can be doing and we should be doing, because we don't have the space for it. So when people are coming in a very treatable phase of this disease and we can't help them, that is turning into a serious ethical dilemma. And this is an ethical dilemma that the entire world has to deal with.
An ethical dilemma, I assume you mean because you're sending people home sick. Is that right?
Yes. And the only reason we're doing this is because there aren't enough treatment centers there. And this is really problematic. When you have somebody coming in and they can be cured for this disease with the proper treatments and they're not getting it, that is a problem.
So you send them home sick where they infect everybody else?
Well, we don't send them home with nothing. We send them home with as much education as we can. We send them home with some masks, gloves, soap, a bucket, and hope for the best.
Let me read this. This is from the New York Times from last month. Soon, the 2008 global financial crisis struck. The WHO had to cut nearly $1 billion from its proposed two-year budget, which today stands at nearly $4 billion. By contrast, the budget of the Centers for Disease Control and Prevention for 2013 alone was about $6 billion. The cuts forced difficult choices. More emphasis was placed on efforts like fighting chronic global ailments, including heart disease and diabetes. At the agency's Geneva headquarters, outbreak and emergency response, which was never especially well funded, suffered particularly deep losses, leaving offices that look, one consultant said, like a ghost town. The World Health Organization's Epidemic and Pandemic Response Department, including a network of anthropologists to help overcome cultural differences during outbreaks, was dissolved. Its duties split among other departments. Some of the main outbreak pioneers moved on. Joanne Liu, I should ask you, can the WHO, can its inability to respond appropriately to the Ebola crisis be blamed on some of the things I just read in that paragraph?
I think that in part it can be blamed about it because the WHO has been underfunded recently over the last decade, more or less. And then basically I would say that WHO has cornered itself in becoming what they call even themselves a normative organization. And they have lost their operational, I would say, capacity. So that's an issue. And this means that the fact that today WHO is not as operational as it should be is, I would say, a collective failure of states members who underfunded the WHO. So for me, I think one of the biggest lessons learned from this epidemic, although we're not over with it, is the fact that we need to do better the next time, because I don't think it's going to be the last one. And we need to make sure that when it's going to come around again, that we're going to have an international governance that will feel responsible to respond and to organize the response. And that's really key, because in this particular epidemic, no one felt responsible and no one wanted to take the leadership. And I don't think that this should be in the hand of a private international NGO. And I just wanted to come back to one of the things about why people are not reacting to Ebola. I think that when you talk about a very, I would say, disease that nobody quite know, remote in a part of a continent in West Africa, as long as it's distant, people are not paying attention. We've been trying to bring the spotlight on neglected disease for decades, MSF, and we're not able. And then the last point I wanted to add is the fact that what does it need to answer to Ebola today? I really summarize it in three things. It needs courage, organization, and discipline. And I thought that it was the most thing that was needed was more discipline, but I realized that we really lack courage.
Well, to that end, you're all far too polite to say it, but let me put it on the table. They're poor black Africans, and the world tends not to care about poor black Africans. Is that okay to say out loud? Is that part of what's motivating the lack of response here? I don't know if anybody wants to jump in on that. Probably not, but
it has occurred to me that, after HIV, AIDS, and after Rwanda, that we might have felt more compelled to do a better job for Africa.
Apparently not. Okay, point made. I get it. Point made. Let's move on. Tim, you want to weigh in on that?
Yeah, it looks like we don't care, plain and simple. I don't understand how a global GDP of $77 trillion can't come up with enough capital to help us in this fight. I don't understand how in a global population of 7 billion, with the highest number of well-educated people with technical expertise cannot be found to help this. It doesn't make much sense to me, and so I guess we can come to some other conclusions, which might not be politically correct, but might be very true.
There we go. I'd like to spend some time now on the lessons learned from 11 years ago with SARS and how those may be appropriate or applicable in this circumstance. I think as we sit here in Leaside at the moment, we have no cases of Ebola in Canada. One suspected case in Belleville, which turned out not to be the case. But it's not beyond the realm of possibility that we could be dealing with this in Canada at some point. In which case, Vanessa, what did we learn 11 years ago that will help us today?
Yeah, Steve, so I was a resident during SARS, and I was at Sunnybrook at the time, and I had moved between different hospitals, and there was a degree of panic in the reality of SARS that I am not sensing here. However, I think the experience from SARS has really led to a lot of investments. To be part of Public Health Ontario in this larger system where we're communicating a lot better and where we need to continue to do so, I think has really been a positive outcome from SARS, but it needs to be maintained. But I think a lot of the frontline healthcare workers that were personally affected by SARS, I think it has reverberations that are very problematic for them. However, what I've seen, again, at Sunnybrook and at Public Health Ontario and working with other colleagues, is in that most people have a dedication that I find really important to be a part of. So how do we make sure our employees are safe? How do we make sure that we train people to put on their protective equipment safely, and really making these robust programs? And we always have more to do. The job is not at all by any means finished, but it's really figuring out how we're dedicated. And it's really the people that I've seen who lived through SARS and are now dealing with it that I find have a lot to teach us in terms of what we should be doing.
Brian Schwartz, what did we learn 11 years ago that could help us today?
Well, I think that first of all, that we need to pay attention, going back to our previous discussion, as to what's going on in the rest of the world. It's not only about them. When it's about them, it's still about us. So that and I think we are better connected. Notwithstanding the comments by Dr. Liu, the WHO does have international health regulations that compels reporting of threats through countries to the world, and we at Public Health Ontario hear about it through our contacts at the Public Health Agency of Canada. So it's that connection. We have connections amongst the provinces now, amongst all the chief public health officers, and the three agencies, Ontario's, Quebec's, and British Columbia's.
So you guys are sharing notebooks?
We absolutely are, on a regular basis. And we're sharing protocols, as Dr. Taylor pointed out yesterday. We're sharing best practices. It's not perfect, but it's better than it was.
Helen, what would you add to that?
I would say the thing that we should have learned from SARS is that we have very short memories. SARS was only 11 years ago. The WHO took a very strong leadership role then, and the world thanked them for it. They did some things that people in Toronto didn't like very much. For instance, the travel advisory, you'll remember, when they told other people from outside the country not to travel to Toronto. That was hugely controversial, but they had the courage to do that. And I think those measures and others really helped to contain the outbreak. A couple of years later, they strengthened the international health regulations. They're not as strong as they could be, and countries don't always report with the
compliance.
Yeah, compliance is an issue, and the WHO finds it acts at the pleasure of the member states, so it's always this delicate diplomatic dance that goes on there. I think in the interim, as we've heard, there's been a lot of cuts to WHO's funding, and so we now find the WHO in a situation where it is much more weak than it was then and unable to respond in the way it did now. I think, you know, somebody told me last week, you get what you don't pay for.
Isn't that a nice way to put it? Huh?
Yes.
Usually you get what you pay for. Now you get what you don't pay for. Very well put. Tim, is Windsor home for you?
Yes, it is.
Were you in the province of Ontario 11 years ago when SARS hit?
Yes, I was.
And what do you think, if anything, has changed between then and today in terms of our preparedness for what might come next?
Well, I think probably that there have been some things learned. I mean, there is a collective wisdom, I think, that has to be held onto actively. It looks as though that collective wisdom does exist in regards to SARS. I know within MSF itself, the reason that we're able to always kind of go forward, maintain our high level of preparedness and effectiveness in everything that we do, whether it's in an HIV project or whether it's in an Ebola outbreak, that's all based off this collective wisdom. What is being learned is constantly being brought back and analyzed and tried to figure out what are the strengths and weaknesses in what has been done.
Vanessa, I don't know what to make of this number, but I'll read it to you and then you tell me what we should think about it. Epidemiologists who study air travel patterns say there's a 10% chance, 10%, that we'll see a case of Ebola here in Canada by the end of October. 2 weeks.
Right.
Not much time. How do you regard that number, 10%?
So I don't know specifically that data, but I do think as a hub of international travel that we have a high likelihood and we have to be prepared. So I'm not surprised, and I think it really is no longer an abstract maybe, and I think that refers to some of the conversation before and some of the disheartening nature of that. But the likelihood that it will come here, I think, is a strong possibility, and I believe that we all need to be prepared, and we're working.
And are we?
I think there's many aspects in which we are prepared. So, you know, there's a lot of guidance that has been prepared in short order with many, many different partners. I think some of the events of late, so in Texas with the 2 healthcare workers, I think with each one of these, it's really an opportunity to review how we can do it better. So one of the concerns is people taking off personal protective equipment that Tim mentioned before. How do we make sure that's done in the safest way possible? Other aspects, so one of the issues that's come up in Canada is how do we make sure the transportation is done in an effective way if people need to get tested? How do we make sure that happens? So with these investments, we're now going to start testing in Ontario to expedite that in the next couple of weeks. So I think.
How confident are you about the labs doing the testing?
Very
confident.
Very confident.
They have not had to test for Ebola before.
Right. So like other jurisdictions, Texas, many other countries that have this preparedness, it's really about being able to mobilize quickly. So we do have a very secure algorithm, but with that, there's added precautions. So at the beginning, everything's tested in duplicate, both with us and at the National Microbiology Lab, to ensure that it's the highest quality. And I think the other aspect of that is that it's done in the utmost safety of the environment. So the procedures are there to decontaminate, to protect all the employees that are doing the testing. And so I'm very confident in that, and we continue to look at better and better ways to do that.
Do I assume that you answer to the Minister of Health? You come under the aegis of the Minister of Health?
Well, yeah, we're an agency of the Ministry of Health.
A good Minister of Health, I would think, when this hit the fan, would have had you on the phone or somebody in your organization and said, hey, are we ready? What if? Has that happened? Well,
I've had indirect conversations with, certainly direct conversations up the chain to the minister, not directly with Minister Hoskins, but certainly we've had those conversations. And you know, are we ready is a tough question to answer, yes or no. It's a dimmer switch. We're shining the light on it. We are taking the lessons learned from SARS, and we have to apply them to this situation. There's hundreds of thousands, 500,000, I think, healthcare workers in Ontario. We think we've got the right information. The question is, how fast and how effectively and efficiently can we get that out to the front lines? And we're still working on that, Steve. It's a challenge. We're working certainly very closely with the ministry and the Chief Medical Officer of Health in getting that information out, and with, in particular, the hospital sector, but also EMS, long-term care, primary care, and all the rest of it.
I presume, though, Vanessa, we've got tens of thousands of people working in healthcare on the front lines in this province, some of whom will come into contact with this at some point in the not too distant future. Are they trained are they up to speed on how to handle all this?
So I think it's a possibility that it could go to any healthcare center, and certainly we've seen examples of cases that have been investigated. There are some concerns about the recency of that training. So if you were trained a year ago, does that make you comfortable in doing that now? And I think those are some of the things that we are looking at now in terms of how can we help and how can we be part of this larger community to enhance the training, respond to the needs of the front line. But the other thing that I just wanted to add to before, I think one of the things of note is that we've actually investigated a lot of people under investigation in Canada so far. And there's a couple of aspects that have been interesting. One is that we found quite a few cases with malaria. And so these are individuals that had there been no contact and not this alternative testing, that something that could have potentially hurt them might have been delayed. And so it's really thinking about Ebola in the context of these other potential illnesses and how to make sure that all of the patients that come to our healthcare system are considered in terms of a potential infectious risk, but also the best management for them. And that's been an ongoing message that we've learned from the data. So some individuals had malaria, some individuals had bacteria in their blood, all very dangerous conditions.
Joanne, you wanted to say something, yes?
Yeah, I just wanted to answer and to react to the cases that we had in Canada. And it's really interesting because what we have seen in our centers in West Africa is the fact that in a very small sample, I must agree, it's only a few dozen patients, but 50% of those Ebola patients were malaria positive. So the thing is, I think for me, the take-home message, it's not because you have a thick smear positive for malaria that you should drop down, your guard about Ebola. That's what we learned the hard way.
Helen, let me ask you about the issue of trust, which came up as an issue 11 years ago with SARS. How does trust play as a thing to deal with throughout the course of treating this situation?
Are you talking about in North America or in Africa? Because in Africa, certainly part of the problem has been because Ebola wasn't known in West Africa. When people in hazmat suits showed up and tried to start interviewing people or taking away the sick, there was a lot of denial that there was such a thing as Ebola. And in fact, what it was seen, which has been seen in other outbreaks, is that the rumor mill got going pretty strong, and the story was, these people are making us sick. It is not, there's no such thing as Ebola. So trust becomes a really huge problem, and I think it's exacerbated by the fact that when people go to treatment centers, they often don't come out, and the families may not get the body back, and that's, it really doesn't help the situation. I'm hoping, Dr. Lou could tell us, I'm hoping that now there is more of an acceptance that there is something real and it's called Ebola there now.
Joanne Lou, you want to help us on that one?
No, I think that there is much more awareness about Ebola right now in West Africa, and I think that actually it's like in Canada, there is massive concern and people are scared. I think we have passed the stage of denial, but the reality is because people are scared and we don't have enough measure to allow them to either change their behavior by protecting themselves, then they go into other type of change of behavior and I would say even panic. So this is what we need now. We need a much bigger, I would say, response in the field to reassure the population that we have the means to help them to change the course of this epidemic. And this is not happening quick enough, then we're all going to be dealing with a massive panic at, I would say, the whole, at a country level.
Tim, did you see evidence when you were in West Africa of culture or a lack of trust for authorities playing itself out?
Yeah, we were seeing that simply because what happened was you had somebody die in a village, and then people come in the next day wearing spacesuits and start spraying, And then more people started dying afterwards. So there was, it's very difficult to explain to many people who don't have a fundamental understanding of what a virus is, that something that's smaller, so small that they can't even see it, can kill them. And this is typically related to black magic, witchcraft, these types of things in some areas. So it's very important for us to be able to have the cultural sensitivity to be able to explain it in a way that they'll understand and in a way that they'll be able to trust the information as being given to them. So these are things that we were working with. And these are the types of things that we have to really pay attention to and we have to respect as we're trying to send that message out. And like one of the most important things is developing that sense of trust. Very, very important that we have the trust of the people.
Brian Schwartz, I got about a half a minute left, and let me ask you, I don't mean it to be a facetious question, but it may sound like it. You know, they say that some people say that these epidemics happen because it's Mother Nature's way of telling us that we're bad. You know, we're abusing the planet, etc.
We're not behaving ourselves.
We're not behaving ourselves, not not taking care of the planet properly. You put any stock in that?
Well, I think we apart from that, we need to take care of the planet, and we need to take care of each other, and we need to educate ourselves, our colleagues in healthcare, and the public about how important it is to protect ourselves from these threats, whether they're infectious or environmental or security threats. And I think certainly we need to share a lot more information. We need to understand the fundamentals of things like hand washing for all infectious diseases, and I'll leave Mother Nature to make her own decisions.
As she always does. Thanks so much, everybody, for sharing your information with us tonight on TVO. We're really grateful. Appreciate it very much. Thanks, everybody.
Support Ontario's public television. Donate at tvo.org.